you know, there's obvious anxiety from the diagnosis to the treatment aspect of it, and specifically if we're talking about a patient that doesn't get neoadjuvant treatment, then once we've identified that they have an invasive cancer and we know their tumor markers, the surgeon can really expedite the conversation or the consultation with the medical oncologist by going ahead and ordering the test. I've found in my practice that can reduce the amount of time towards that consultation and towards a beneficial consultation with the medical oncologist by upwards of 2 or 3 weeks. So again, if you're knowledgeable of the biology of the tumor and those patients that are good candidates to get this genomic profiling, then that lowers the anxiety for that patient to not only have that consultation with the medical oncologist, but to understand what that consultation is going to involve. So we can begin to educate them to a situation where, you know, you may not need chemo, or you may need a combination of chemo with the endocrine therapy, or maybe just the endocrine therapy alone. So I like to do this testing prior to the medical oncologist seeing them in the appropriate patients. I've had 2 interesting scenarios that have occurred in the last 2 or 3 months, where one lady that was, I think she was still premenopausal, and she only had 1 positive node from her sentinel node procedure, and she was ER/PR positive and HER2 negative, and she actually had her medical oncology opinion prior to testing, and then we kind of all agreed that maybe we should go ahead and do the genomic profiling on her, and her risk score was like 2%. So everybody kind of backtracked and said, wow, maybe you don't need chemotherapy in this situation. And she actually saw another medical oncologist, and she only got endocrine therapy. So that was a situation where a patient was overestimated their risk based on age, tumor size, and lymph node status. But when you apply the biology of the tumor, the genetics of the tumor, her risk was not high whatsoever, and she avoided chemotherapy. Then I have another scenario where, and this one happened just about a month ago, where she was 63 and postmenopausal, ER/PR positive, and about a 2-centimeter tumor. And everybody was communicating with her, oh, this is a favorable tumor, you've got hormone positivity, but we're going to go ahead and do the genetic testing. She was thinking she wasn't going to get chemo, and her risk was 35%. So she was in the high risk category, so she did get chemotherapy. And so both extremes. So it's not common, but it does change your treatment over, what, 37% of the time.